afternoon.
I'm going to make it quick and interesting so that we don't sleep. So basically here we are looking at how many cases of renal failure are attributable to prostate cancer. Next. So just as an introduction, prostate cancer is the second most common cause of cancer-related deaths in older males after lung cancer. And a review of more than half a century from 2007 backwards by Magoha showed that the incidence of prostate cancer is increasing in Africa, and it was probably the most common urologic malignancy in black Africans. In Kenya alone, the incidence has increased by 75% over the last decade, with over 1,000 new diagnoses, making it only second to the esophageal cancer, according to the Global Cancer Study. A review by OCK in 2007 at KNH showed that more than 85% of the patients presented with advanced disease, with either clinical stage 3 or stage 4 prostate cancer. Now, with this information in mind, we sought to identify the renal impact of prostate cancer in Kenya. Next. So we did a retrospective review over a period of 18 months. And we looked at the clinical presentation, the creatinine, the PSA, the Gleason's comorbidity, and the treatment, and ethical review was permitted by the KNHOA Ethical Review Committee. Next. So before we go into the renal impact, let us get the general picture of prostate cancer in this country. The mean age of the patient we studied was 72 years. 75% had metastatic disease at diagnosis. 6 were diabetic and 8 were hypertensive. If you see from this picture here, the most common reason for hospital visit was obstructive lower urinary tract symptoms. Almost everyone had this. 26% of the patients had radiological evidence of lumbosacral metastasis. And interestingly, all these patients came complaining of low back pain. And another interesting bit is that the mean hemoglobin of those who had lumbosacral metastasis was significantly lower than those who did not. 22.5 had unilateral lower limb swelling due to lymphatic obstruction or DVT. 15% had pulmonary mets, and 12.5% had mets to retroperitoneum and other abdominal viscera. Next. This confirms what we are saying. This is the real picture of what prostate cancer is in this country. The first picture you see is a patient who came in with fulminant pulmonary metastasis. In fact, he had pleuropulmonary met to both lungs. This other shows metastasis to the lumbar vertebrae, and if you see carefully here, the L5 has been eaten. This patient also incidentally had right hydronephrosis. This third patient here has presented with bilateral pulmonary nodules with a bit of fibrosis and effusion. And this last patient here came in with metastasis to the pelvic bone and osteopenia of the right hip. Next. And the labs confirm this picture because the average PSA of these patients was 410, with some coming in with a PSA of 4,000. The mean Gleason score was 8.6. Most of the patients were anemic, others were coming in with a hemoglobin of 3.8, which were basically they were in CCF. And as I've told you before, those patients who had lumbosacral mets had significantly lower HB than those who did not. On further analysis, it showed that 85% of the patients came in with a PSA of above 50, over 90% had a Gleason of 8 and above, and half of the patient was severely anemic at the time of presentation. Next. Now let us look at the renal impact, which is what this study sought to establish. As you can see, 50% of the patients came in with hydronephrosis. Their average creatinine was 310, others coming in with a creatinine of 976. Going with the cutoff values that were used in other studies, 57.5% of our patients, they were in renal failure at the time of presentation, with 45% requiring immediate dialysis. Now, a subset of patients which is 14, not 8, that 4.8% developed CKD 3 months from down the line, which means they came in with abnormal creatinine, but 3 months down the line, they continue to have abnormal creatinine. So they were labeled as having CKD. So what we are saying is that 34.8% of our prostate cancer patients develop CKD. The most important predictors for CKD was presence of metastatic disease at diagnosis, presence of hydronephrosis. In fact, hydronephrosis was associated with an odds of 10.5 of developing CKD. But the most important predictor for CKD was anemia, because patients who had anemia of less than 10 at presentation had an odds of 24.5 of eventually developing CKD. Next. This confirms what we are saying. The first picture on the left shows a patient who had severe bilateral hydronephrosis. You can see the kidneys are almost becoming a bag of water with severe thinning of the corticomedullary junction. The second patient had significant bladder outlet obstruction, appreciate the thickness of the bladder wall, and that is the culprit right there. You can see the nodules, which the prostate is very huge, and it turned out to be cancerous. So what we are saying is that our patients are presenting with these huge obstructing prostates causing obstructive uropathy or obstructive nephropathy, as you like to call it. Next. As far as treatment is concerned, 50% of the patient received channel TURP as a form of relieving the urinary obstruction. Now this is important because it shows that the clinical presentation of our patients is dictating our management. Because the patients are presenting with this huge obstructing prostate causing obstructive nephropathy, 50% of them ended up requiring channel TURP. But the most important, the most common was ochiectomy, but none of these treatment modalities was given in isolation. Most of them were combined. So 70% of the patient received combination therapy. And none of this was meant for, in most of the cases, it was mainly for palliation because it was advanced prostate cancer. Now the interesting bit is that those who needed TURP because of obstructive uropathy had a mean delay time of 2 months before they got this procedure. Even those who required dialysis, they had a mean delay time of 3 weeks before they got it. Next. Now is the discussion. Next. So we looked at, has the incidence of metastatic prostate cancer changed in Kenya? We compared our study with that by Wasike that was done 7 years ago at the same setting. And as far as we are concerned, metastatic prostate cancer seems to go towards the older age, which is not a bad thing, and the incidence has slightly dropped. Why? Is it because of the more widespread use of PSA these days? Is it due to more awareness of the disease? Especially when the former Minister for Health was diagnosed with prostate cancer. I'm sure most of us have different opinion about these issues. Next. Now we compare the incidence of metastatic prostate cancer in Kenya versus the other country. You can see this study here, adenocarcinoma of the prostate gland in Iceland. They found that 33% of the patients had metastatic disease at diagnosis. A study from Boston found a range of around 4 to 10%. As far as we are concerned, the mean age seems to be around no much difference. But as far as Gleason score is concerned, more of our patients are presented with aggressive disease and poorly differentiated tumors. Next. This is among the first study to show the relationship between BPH and CKD. It was from Mayo in 2005. They found that patients who had BPH had 3 times higher risk of developing CKD. And it could occur as fast as 2 to 3 months. And they actually suggested that BPH will be considered a factor when evaluating a patient for CKD. So we asked ourselves a question: if BPH carries 3 times higher risk for CKD, then why not see a prostate? Because our patients are presenting with this huge obstructing prostate. What is preventing them from getting CKD? Next. In Europe and America, since the introduction of PSA in the 80s and 90s, the number of metastatic prostate cancer diagnosis has significantly dropped, same as the one which causes obstructive uropathy. That is why they are regarding it as an old problem. People are quoting figures of 1 to 3%, but here 50% are presenting with obstructive uropathy. So in this part of the world, things are very contrary to that. Next. Does obstructive uropathy due to prostate cancer carry poor prognosis? This first study here from Canada that looked at AKI due to bilateral uterine obstruction found these results. Next. Obstructive uropathy due to prostate cancer. Those patients who had obstructive uropathy due to prostate cancer, their mean survival was 190 days, which means obstructive uropathy due to prostate cancer is more lethal than that due to bladder cancer or cervical cancer or even lymphoma. Next. This study here from Cleveland in Ohio found a 19% obstructive uropathy prevalence. Our study found 50%. Now in this study they found that patients with obstructive uropathy due to prostate cancer had significantly inferior survival than those who did not. 41 months versus 54 months. In our patients, we don't know because we didn't look at the outcome. So future studies need to do that. Next. Now we want to look at the prevalence of renal failure attributed to prostate cancer in other parts of the world. Next. This study here from Manchester found a 23.5% renal failure prevalence and half of the patients were dead at 2 years. Next. This other study from Minneapolis found that 2% renal failure incident, but interestingly, more than 75% of the patients regained their renal function with immediate PCNL. Next. This final study here from Milan found a 36% renal failure incidence. Next. Now if I give you a summary of all these 3 studies that I've shown you, the one from Manchester found a renal failure at 23.5, the one from Minneapolis 32, Milan 36, in Kenya it is 57.5. So this really shows the renal impact of prostate cancer in this part of the world. Next. How should this patient be treated? Next. This review here from Germany found that patients with obstructive uropathy who received androgen deprivation had significantly inferior survival than those who received PCNL or stenting. Go next. if you see in this table that I showed you before, if you combine orchiectomy and homolog, these two patients had both, these are form of androgen deprivation. It means that 80% of our patients actually had some form of androgen deprivation. Just one more minute. One more minute, please. Okay. So basically what you are saying is that our patients are presenting with this lead disease, and I would like to get your views regarding your experiences. Thank you so much for the